So we'll go on to the second person is not there, so we'll go on to fundus fluorescent angiography. Thanks. So this will be a short presentation. I will not be going into the basics of and principles. We will be just looking at a few case examples to give an idea of where all we can apply this investigation in making a diagnosis or deciding on the modality of treatment. So by using the fundus fluorescent angiography, you can look at the optic disc, the retinal vasculature, the macula, and tumors and other inflammatory disorders as well. So for example, this is a case of a 47-year-old female who came to us with complaints of defective vision in the right eye, and she's a known diabetic. And what you see here is a clinically significant macular edema, or DME as you would call it nowadays. So we see that it's involving the fovea. And how does fluorescent angiography help in this situation is, suppose you feel that you want to do a laser for this treatment for this patient, then you need to know which are the aneurysms which are leaking. And once you do a fluorescein, you can make out that there are multiple aneurysms which are getting fuzzy as the angiogram progresses. So now we know it's a focal type of maculopathy where the leakage is from the aneurysms basically. And so in this case, you can just superimpose and see which are the aneurysms that need to be treated. Normally when you do focal laser, we don't hit every aneurysm in the fovea. You can see that here, the aneurysms which are mainly required, which need to be treated, will be this group of these 2-3 aneurysms here, this aneurysm here, and these aneurysms here. And I can forget about all these aneurysms. So when you do focal laser, we have to target the aneurysms which are causing the edema. So we can try to superimpose. Here you have the edema in this zone, and try then look at the angiogram and try to see which are the leaky aneurysms, and rather than hitting the macula indiscriminately, you can just focus on these aneurysms and decide where to put your laser, focal laser. So also if we have diffuse CSME, we know that here you can see the whole capillary bed is leaking. So in these cases, we know that grid laser has to be done, but usually after the injections have come, the grid laser is, because of its low efficacy, most of the time we are giving either intravitreal anti-VEGF or intravitreal steroids in these patients with diffuse macular edema. So you can assess whether it's a focal maculopathy where the aneurysms are leaking, or the diffuse maculopathy where the capillary bed is leaking. So one of the main indications of doing FFA in a diabetic patient. And also we need to look at patients who need not be treated with laser because of the presence of macular ischemia. So how do you diagnose macular ischemia? Again, now we have the OCT angiography, but before that we used to do it only with the angiogram. So 3 key points to assess macular ischemia. Once you have to look at the intercapillary space around the foveal network. Normally it is so tightly woven that you hardly see the individual vessels in the capillary perifoveal network. But you can see the gap between these two. That means there is loss of capillaries causing the widening of the intercapillary space. Second point would be the capillary budding or aneurysmal formation at the edge of the FAZ margin. And third will be both the irregularity as well as the enlargement. Normally it's a very uniformly horizontally oval structure, FAZ. If it is irregular or if it is enlarged, both will indicate there is macular ischemia. So these are the 3 key points to look at in the fluorescent angiogram to diagnose macular ischemia. And once we have this, we know that the patient is no longer fixing with the fovea and the patient is fixing with the perifoveal zone. So we are going to hit this area with the laser, you are going to damage his seeing area and make him blind. So in these cases, it's better to go for injections, or if you want to put the laser, you see that the laser does not encroach on the perifoveal zone where currently it is the fixation locus for that particular patient. So macular ischemia, laser is not a usually not indicated in these sort of eyes. Then we can also use it to look at the presence of capillary non-peripheral. Sometimes you see that one eye is having a vitreous hemorrhage or a large new vessel, but when you look at the other eye, you're not seeing much changes. So whether we are having a symmetric DR, normally DR is symmetric, and you have to, if you're not sure that you have examined the patient properly and you're afraid that he may have a featureless retina where the clinical features are not very well demarcated. But if you look at the fluorescent angiogram, you can see the extensive loss of capillary, indicating that he is a pre-proliferative disease, and you may need to treat this eye also, apart from treating the eye which has already got a proliferative disease. So this may help you in deciding those sort of intervention. And also when you see abnormal vessel, to distinguish whether it's a NVE or NVD, or NVE, or if it's a IRMA. So IRMA is usually seen to communicate between the arteriolar and the venular system, and it is usually seen within the area of ischemia, whereas NVEs are seen as a junction of ischemic and non-ischemic zones. So it can help you to, and also depending on the leakage, also leakage is much more in NVE, very less or absent in IRMA. So it helps you differentiate between, when you see an abnormal, right away you need not jump to conclusion whether it's NVE, and if you're not very sure clinically what it is, then you can do a fluorescent angiogram to confirm what it is. So on my picture showing the large IRMA which is not leaking at all, whereas if it was a new vessel, it will profusely leak in these eyes. So also sometimes you have media opacities like cataract or asteroid hyalosis, where you can see that you cannot see the retina at all during a slit lamp photograph or a color fundus photography. So you may miss out on the posterior segment pathology if you are trying to see through this haze. So, but when you do a fluorescein, these are no longer disturb or photograph taking. You can see the presence of newer cells. You can even pick out the preatal hemorrhage in these eyes. So indicating that these eyes need to be treated. So now we have the larger widescreen fundus photograph where you can even see the extreme periphery. The conventional photography can reach only till this zone, but the recent days we have been seeing the extreme wide field angiographies where you can pick out disease which is even the periphery, and sometimes this can be the reason for improper recovery following treatment. So you can try to target these zones during laser, so that wide field angiography has helped in making us understand the nuances of all these diseases, vascular diseases. This is the second case where we have again a female patient who's got complaints of defectation in the left eye, who's a known diabetic and dyslipidemic patient. You can see that there is a central retinal vein occlusion, and in these cases you can try to prognosticate by looking at the FAZ whether she has got a significant macular ischemia, giving a good prognosis, a bad prognosis following a therapy. Also it can be used to document the progression from non-ischemic to ischemic. You can see extensive non-perfusion areas here. And also if you do the wide field angiography, sometimes you that central area may be normal, but you can see extensive non-perfusion in the extreme periphery, which is not usually picked up with conventional angiographic techniques. So what looks like a non-ischemic CRO can have significant non-perfusion in the periphery, which may lead to NVI development in the later stages. And also in vein occlusions, you can look at the amount of involvement, whether it's how much is involved in the fovea, helps you to prognosticate. And if you plan to do laser, if there's NVE here, you can look at the area which is need to be treated, and it can also help to differentiate between hemi-CRVO and large BRVOs also. And sometimes mimickers of diabetic retinopathy, sometimes we see hard which we need not directly jump to diagnose of diabetic retinopathy. You can see that there are some codes like telangiectatic vessels, and these need to be targeted. We no need to go for a PRP, only target these areas and it will resolve. Again, one more codes we see showing the only localized non-perfusion and the aneurysmal dilatation. So one more indication where we see is in the presence of ARMD. So it helps you to diagnose what type of disease it is. Here you can see that there is a diffuse leakage is picked up more in the late stages. You can see the disease process is mostly confined below the RPE, indicating it's an occult type of CNVM. And in this case, you can see that it is picking up very early and profusely leaking in the later stages. And you can see that in OCT, you can see the neovascular tissues just above the RPE. Thereby, the RPE is not obstructing its visibility. So easily we can go for a PDT if you want, or injection. Also the atypical types where you can see the abnormal vessel dipping into the choroid. Note this point where there's a retinal hemorrhage instead of subretinal hemorrhage, and you can see there's a dipping of the retinal arteriole into the choroid, indicating it's a retinal angiomatous proliferation. So these cases are usually resistant to injections and may need a PDT. And also here you have a PCV, polyportal choroidal vasculopathy. You can see the red dots there. And this types again not very resistant to anti-VEGF therapy. In FFA, usually you see that there is only a diffuse leak, but we can see in the ICG angiogram, you can see that there's a cluster of polyps, which is indicating it's a polyportal choroidal vasculopathy, and the inverted U-shaped elevations in the OCT, indicating it's a PCV. And these patients need to be treated with PDT more often than not. And in my high myopic cases, when you have a small hemorrhage, you are worried whether it is just a Fuchs hemorrhage, where it's because of a lacquer crack, where there's a rupture of the Brooks membrane, or where it's a secondary choroidal neovascular membrane. A lot of times, you see that OCT is not easily picking up the disease. You can see that there's no surface edema, no SRF, no CME, but you see something abnormal here. An angiogram tries to clinch the diagnosis, where you can see a choroidal neovascular membrane there. So it's one of the very indispensable tool in making a diagnosis between routine hemorrhage and CNVM. This is again a case of CSR, where you can see the leaks in the multiple pinpoint leaks, whether it's a smokestack leak or in a giant CSR where you have a diffuse RPE epithelopathy, where you may want to do a TTT or a PDT, because these are very resistant to conventional laser treatment, or if you want to go for a eplerenone or rifampin therapy. And you can see the, when you have like this, you're suspecting macular choroiditis, but when you do FFA, you can see it's actually a CSR lake where there's a subretinal fibrin. It helps you to differentiate between all these things. And also inflammatory disorders where you can, between non-inflammatory and inflammatory, where you have choroiditinitis, or when you have VKH syndrome, which mimics a CSR. All these cases is APMBP, which is again mimicking a CSR. So all these can be differentiated with using fluorescent angiography. And there are some, mainly when you want to do this, a diffuse, a localized choroidal hemangioma, where you want to do a PDT, or when it's a vascular proliferative tumor. One more case of vascular proliferative tumor, you can look at the areas which need to be treated with the TTT or PDT. And also the presence of CNVM in a patient with choroidal osteoma, a melanoma, and also in optic nerve disorders to differentiate between where there's a differential filling, or when there's optic neuritis, or when there is a diabetic papillopathy. And also when you have a differentiating between posterior scleritis, also when you have extensive leakage, it's not optic neuritis, it's most probably other posterior inflammatory disorders. Thank you.